incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Hello, good morning, everybody. It's a beautiful Saturday here, at least where I'm based in Manchester. It would be lovely to know where everyone is based. We're so happy to see you here with us in Health Hour with already 129 participants. Today, we have a great session. We are looking forward on are you falling over, mobility and falls in older age. So this is going to be a very interesting topic to dive in. With us, we're going to have our guest speaker, Reverend Canon, Dr. Patrick Anochie, and our host, Dr. Patrice, that has been a long-standing supporter of Health Hour. So I would like to say, as always, that these things are not done alone. CAN works with other organizations, and CATIP is the collective effort of multiple organizations. So our partners are RAFA International Agents, Croydon BME, Enfield Caribbean Association, the Royal Assembly of Sheffield, Black Health Initiative, so BHI, and obviously CAN, Caribbean African Health Network. So everybody, welcome, and I'll pass it to our host, Dr. Patrice.
Thank you very much, Natasha. I am really honored to present our guest speaker this morning. He's a faith leader as well as a consultant in elderly care, Reverend Canon Dr. Patrick Anochie. And as Natasha said, he's going to speak about mobility and falls in the older age group. Today, we are going to cover age-related loss of muscle mass, posture and balance, and postural blood pressure, and long-term conditions such as dementia, complication from falls, and prevention of falling over. So I'll hand over to Dr. Patrick Anochie, and we are looking forward to hearing a lot from him. Thanks very much.
Thank you very much for having me here. It's my pleasure to be part of this network. Ideally, I am an African, so I'll just be a member of this ongoing. And by the grace of God, I want to appreciate Faye and all of you who made it possible for me to be here, and my lead missioner of the Anglican Missionary Congregations in UK and Europe, who is always giving his full support in such enlightenment program. So we go straight to the points. I'll try and keep to time. It's quite a broad topic to talk in 45 minutes and then take questions from there. So we'll do our best. I'd say to highlight areas that are so I hope I could be heard because they're saying unmute yourself or something like that. So I'm expecting at the end of this, we'll have some main outcomes, which is physiological changes with aging, recognize multiple morbidity. I'll explain all these terms so that people understand it. If you're not medical, you should be able to understand it as well. You know, complex problems in elderly people and just 1 minute. Yeah. And then distinguish between physical, psychological, and environmental factors which cause mobility, immobility. And then we discuss clinical probable causes of falls and talk about the, falls prevention approaches. And then it's good to recognize some factors for these falls. When we mention about falls, I'm going to talk about falls and frailty, and then we see how important they are to an average person, especially all the geneticians, and describe the investigation, some of the investigation we do and the effects of polypharmacy. Polypharmacy is when people have more than 4 different tablets, and they will classify that as polypharmacy. So the knock-on effect. So we'll take time and look at all these things. Then one of my major, one of the things I tell people is fall is often a symptom of an underlying problem. It's not a normal part of aging. So when people are falling over, it's not because things are not normal. So it's not normal to fall. I know most of us here are not old, so you can imagine yourself. If you can remember when was the last time you fell? Maybe some of us have not even fallen in 5 years. You understand? So about elderly people fall, frail people fall, and then we tend to say, oh, it's synonymous with them. No, it's not. So there's always something causing this fall. Yeah, and then it's interesting to know that the second largest cause of unintentional or preventable injury-related deaths worldwide is due to fall. So you can imagine how serious we have to take it. And that's second to road traffic accidents. I brought us some figures here. You can see about worldwide, about 1.2 million people die every year from road traffic accidents. The second most cause of death that is preventable or unintentional is fall. So you can imagine. So that's a very important thing for us. So we're talking about growing older. Individuals grow old, they experience increased susceptibility to stressors, things that they meet every day, stress, due to gradual deterioration of the molecular system. I don't want to go very highfalutin. Tissue degradation and organ-specific malfunctions. What I mean organs like the heart, the lungs, kidneys, liver, all those things degrading and ultimately leading to decreased capacity to do their function. That's what all this big grammar is here, to maintain homeostasis and regulate adaptive mechanisms. So as we age, there's decline in the activity, decline in ability to maintain these things the way they used to be when we're younger. Now, this multi-dimensional frailty affects multiple physiological systems in older adults, making it difficult for them to maintain balance. When somebody cannot stand without swaying to one side or the other, when coordination and spatial awareness is lost. Let me give you an example of what I mean by coordination and spatial awareness. I know now if you go out there to use the elevator or the stairs, you don't need to look down to know where you place your leg at each particular step and you're climbing. But when people are old and they've lost this part of the spinal cord, posterior column, you find out that their coordination becomes a problem. They've been climbing steps, they're trying to put their legs, are they in the right place? If I have this cup of water, I can close my eyes, I'll direct it to my mouth. But if you lose that ability, it becomes a problem. So you can imagine so many things that make people to fall. Okay, and then let me give some statistics. Annually in Ireland, more than 7,000 people aged 65 and over required to be admitted into a hospital because of the fall. Now, in England, they talk about the aspect of one of the complications of fall, which is fragility fractures. And I don't want to go into, because of time, osteoporosis, when the bones are quite brittle, that at the slightest, if I fall now from the height I'm standing, I will get up. I'm sure I'm not going to break my bone by God's grace. But an elderly person with very brittle bones called osteoporosis or osteopenia, they're going to fall and they're going to crack their bones. And they end up in hospital with fractured hip and other aspect bones. So at the broad classification, of describing the physiological changes associated with aging process, I'm bringing this thing so that we understand. So there are cellular hemostatic mechanisms with the blood, the body temperature, extracellular fluid volumes, general decrease in organ mass, Let me use brain as an example. If you scan somebody's brain, young, maybe myself, most people, you get that, the space between the skull and the brain tissue is not much. But if you scan an elderly person, the brain has shrunk a bit. So the gap becomes more. So that means there's more movement inside the skull, more than it is. So, and this is another big problem. And then the kidneys with age, they shrink. That means they do less work than they should normally do before. The liver and all those things. So that's what I mean by decreased organ mass. When I talk about blood, of course, the blood, the bone marrow is not as effective, not producing blood as it should be. All these things impact, loss of functional reserve. So when all these activities are going on, the organs, what are their functional reserve? Their ability to be strong and withstand things. Oxidative damages, abnormal cell activities. That's why you get cancer quite prevalent in elderly people, because the ability to modify normal cells and repair them might not be will not be as effective. Protein modification, glycation, talking about glucose, sticking to cells more and more, wear and tear of the body, aging and evolution. Example of wear and tear, if I want to bring our minds to it, like arthritis, bone osteoarthritis, when the bone for years have been rubbing each other, and especially the knees and all those stuff, and then the cushion in between are gone. So these are kind of things you get when we talk about physiological changes. I'll go to risk factors for falls. There are a lot of things that are, I grouped it into 3. But one thing, when I see people in the clinic or in the hospital, what will make me know they're prone to fall? I wrote here the best predictor of falling is a previous fall. Falls in elderly people rarely have a single cause or risk factor. We'll see all those. A fall is usually caused by complex interaction amongst many other things. It might be as simple as it might be intrinsic factors, like I explained earlier, age-related decline in function disorders, and probably adverse drug effects. And what do I mean by that? Somebody might be on antihypertensives normally, and maybe when he was younger, they started taking amlodipine or lisinopril, all those antihypertensives. And when the homeostasis changes, they might not even know. The only way we find out that, look, this person, before the blood pressure used to be 150 and above, and he or she is taking antihypertensive to bring it down to 120 and below, to now he's falling, or he or she has fallen and has been feeling dizzy, and then they end up in hospital, find out that they've been religiously taking their medications, not knowing that their new normal blood pressure, even without medication, is 100 over 80 or 100 over 70. So you can imagine when they now take the same dose of medication, it brings it down to like 80 over 40. We see these things in clinic, in hospital. The person might be feeling woozy, dizzy for a long time, and you're wondering, you won't complain. So that's what I mean by, adverse drug effects. And I'm just giving a typical example. Extrinsic factors, external factors, environmental hazards, wet surfaces, clutter in the homes, for old people, so many things affect them. We'll explore these things much later. And then situational activities, situational factors. related to activity being done. Maybe somebody rushing to the bathroom. Why rush? Take your time. On occasion, somebody might say, "Oh, my son is calling me from Nigeria, calling me from Australia," and rush out to go and get the phone because he said, "I'm going to call," and he's gone to the weak flu, and then ends up on the floor because of situation and maybe not take that call, sadly. So intrinsic factors, like I said before, can impair a system involved in maintaining balance and stability when standing. There's always an increased risk of falls when all these things are not in equilibrium with each other. Things as visual acuity, being very wrong, using the wrong glasses. You can remember every 2 years you're supposed to go and review your glasses at all. Even if you don't have any underlying things that bring you to the hospital more often. People, how do they react in dark and light? How does their muscles, how does their eye react? Changes in muscle activation patterns and ability to generate sufficient muscle power and velocity. It's not easy to just stand up for a lot of people. It might take them a while to just stand up, push up from their chair. The physios will tell you this, and ability to maintain, recover balance in response to innovations, stepping onto uneven surfaces. So there's some intrinsic factors. I try to bring them up here. Muscle weakness of any type is a major predictor. Be it the arm muscles have gone weak or the leg muscles or the proximal muscles, so they all in fact impact on this. Then chronic and acute disorders, infections. One of the major reasons we see in the hospital when people have a fall, we have to look into a long list of causes of this fall. And then we look at infections is one of them. What do I mean by arrhythmia? Many people have palpitations. They don't know what sort of funny readings that's going on in their heart. Some of these readings make the heart to stop momentarily, and the person ends up on the floor. So that's one of the things when people come to hospital and they're calling and say, "Oh, doctor, I want to go home." I say, "No, but we need to sit you down and monitor your heart for 24 hours. Especially when we don't find anything causing this fall, but it's just gone like syncope and just collapse. Went shopping, collapsed. And they say, before the ambulance came, he's come round. It may be arrhythmia, the heart just stopping. And the use of drugs are major risk factors for falls. I'm talking about your prescription drugs. If they're not reviewed quite often, some of them become a big problem as well. Then I want to talk about those that abuse over-the-counter drugs. Then the risk of falls increase with number of drugs taken. I mentioned before about polypharmacy. If you have to take more than 4 medications a day, well, if they're necessary, you have to take them, but it puts you at a risk of fall. It needs to be reviewed and altered here and there. Barbiturate, these are anti-epileptics, opioids. There's over-the-counter cocodamol, tramadol is on prescription now, vitamins. Most commonly reported as increasing the risk of falls. Benzodiazepines are, like diazepam, all those kind of things. So they tend to cause indirectly, related to falls and related injuries. And I mentioned about the environmental factors that increase the risk of falls, more interacting with intrinsic factors. Remember, we said not just one thing brings about this fall, a combination of a lot of things. So risk is highest when the environment requires greater postural control and ability. Example, when you're walking on a slippery surface, of course, you need more care than when you're walking on a non-slippery surface. And things like taking an elderly person to holiday, he's left his own environment. They can close their eyes, they move around their own flat, they know where the furniture is, they know where to make their way to the kitchen. You can imagine taking them for a lovely camp holiday and book them in a place, and then it's dark and they can't find their way around. Or when they've just recently relocated to a new home, there needs to be some care and education with this. I mentioned about the situational factors. One thing here is, when multitasking becomes at a disadvantage, people are multitasking and forget themselves, forget that, there is something here that could be a hazard. And then, like I said, rushing to the bathroom, doing 2 things that they're talking on the phone, distracted, and trying to cook or trying to get something, and they forgot that even your animal. Some people have have tripped over their animals and ended up in hospital because they forgot that their dog is in front of them or their cat, and they stepped on it and off they go. There's so many things, involved in all these things. Now, I brought in this frailty because that's something people just say, oh, he's frail. He's not frail. So what do you understand by the word frail? Being old doesn't necessarily mean that you're frail, but you can see that about 10% of people aged 65 years and above are frail. And then as the aging increases, for obvious reasons we've just discussed above, less function with the organs and all those things, like up to 25 to 50% of those in a given population of 85 years and above, according to the British Geriatric Society, are termed to be frail. And then frailty is a distinctive health state related to the aging process in which multiple body systems gradually lose their inbuilt reserves. So the things you normally do, and I'll explain further. I'm happy to be asked questions, to be brought back to all these things. I'm looking at my time. God help us. So I brought two things that we use in assessing people to know when they are frail, legally or something. When you see these people in the clinic, when you see our elderly population, friends, parents, aunties, in the clinic or in the hospital, when you say they are geriatric giants, frailty syndrome, there are so many of them, but the ones that will affect us, that are common to us, when you find out somebody is falling over, collapse, legs gave way, you came to visit, found lying on the floor, and then, these things are not just one-off, because in the clinic, I normally ask, have you fallen in years? When was the last time you fell? To tell this, I say, any other time, after this fall you had last week, when was the last time you fell? Though elder people don't like telling you that they're falling, so you have to prove. So if I say, oh, just 2 weeks ago, oh yeah, it just only I was just changing my knickers and I just fell. Something one lady told me, and she was as crisp as anything. I didn't know she had an MI, a heart attack. That's what made her to fall. So we find out all those things. Immobility, find out this person has gone off legs, stuck in toilet, can't even stand up. And these are things that tells you this lady is getting frail. Delirium is an acute confusional state, muddledness, it's acute. Because delirium doesn't mean the person is confused all the time. No, delirium doesn't mean the person has got dementia, but it's a sign that tells us somebody may have underlying or tending towards that if things make them muddled so easily and, worsening of confusion with previous dementia or no memory loss. It makes delirium very, very evident, very quick. But it's an acute confusional state. People might just have simple infection like UTI, urinary tract infections, or even chest, any infection at all. And then you see him and say, do you know where you are? He or she will look around and tell you that he's somewhere far away. I once woke a lady up and asked her where she is. In the hospital, she looked around and told me she was in Buckingham Palace. I said, okay. And I told her where she is. I know there was something going on there. And then other one is people becoming incontinent. It's embarrassing. They can't even hold their wee anymore. New onset of urinary incontinence or leaking feces. Let me tell you, let's not forget, not everybody that is just leaking urine is termed frail immediately. It could be things like urinary tract infection can just make someone leak urine. So these are things for us to pick up. And then people, like I mentioned, can be on a particular medication. At some point, they take that same medication, they go completely confused and agitated. We see it a lot with things like codeine, or somebody takes his normal antihypertensive medications and next thing he ends up on the floor because he dropped his blood pressure more than he should. So these are things that make us know that somebody is frail. Frailty, old age is not a death sentence. It just makes you know how to manage this person and understand the risks involved. Then another question here for guys, please, sorry, if you're 85 and you use a walking stick, you're frail already. If you're 85 and above. So look at this Prisma, 7 questions. If there are 3 yeses here, that denotes frailty. So are you more than 85 years? That's, remember, it's not one of them makes you frail. It's 3. Are you more than 85? Are you a man? Now, in general, do you have any health problems that require you to limit your activities? For example, you've got heart failure or heart problems. You find that if you now walk very briskly, that you're going to be out of breath, and then you start limiting yourself. Do you need someone to help you on a regular basis? Do you, in general, do you have any health problem that require you to now stay at home? In case of need, can you count on someone close to you so that you're being quite dependent? And then do you regularly use a stick, a walker, or a wheelchair to get about? So I have an 89-year-old dad who uses a walking stick. Automatically, number 1, 2, and 7 makes him a frail old man. So, you know, I'm just bringing all these things for us to. I brought out this terminology just to differentiate these things, so we don't confuse it. It's important to understand the difference between frailty, long-term conditions, and disability. Many people with multiple long-term conditions, multi-mobility, will also have frailty, which may be masked when they focus in one another. So frailty, we've described what frailty means, all those things I said in the previous slide. And then long-term conditions, you know, these conditions can be managed, but they're not curable, like hypertension, heart failure, diabetes mellitus, you know, name them. They could, Parkinson's disease, they could be managed for years. The disability, you can imagine when somebody has a permanent challenge, the disability, maybe the person is paralyzed after stroke, and you know, so unfortunate that this sort of thing happen. So these are just to know the differences. Multi-morbid and complex conditions in elderly, chronic stable conditions like I've mentioned a lot before. If you don't know what atrial fibrillation is all about, it's one of the major risk factors for stroke. You know, where the heart is quite irregular, you can even diagnose yourself and confirm with a doctor. It's quite irregular, touching your pulse, and you can see it's flipping all over. Just get it diagnosed, because the risk factor, what it means is that as it's beating, the heart is irregular, so it makes the heart more susceptible to build clots that can be dislodged and go to the brain to cause a blockage of artery and cause stroke. And that's why when we pick that up, we counsel the person, weigh balances, and start the person on the blood thinner, keep the blood thin, and prevent clots. All impact on the functional reserve and provide a less resilient physiological challenge than a younger person without them. And what do I mean by this? Now, when people have chronic conditions, you find out it makes them less resilient to things. Maybe somebody used to fast for 12 hours, maybe with diabetes, find out that, look, after fasting, he's completely washed, you know, completely not able to cope, even though we don't advise before you fast, please make sure if you're not used to it, you're starting new, talk to your doctor and then you review things. So these are what I mean that we find a lot in the elderly, little things. They're chronic, they're stable, well managed. All these things I've listed here could be well managed, but they stay impact. Yeah. Clinically assessed probably causes of falls. That's I brought up this because there's something we use in the clinic. It's called get up and go test. You know, as simple as walking 10 feet. And if you walk somebody to walk 3 meters in a straight line, in the office, you say, can you walk to that door and come back? And you time how many seconds. That will help you see, is this person quite stable? You know? So if somebody can just walk to a 3 meter, stand up from the chair, walk there, turn around, and come and sit back in the chair. If he does this in less than 12 seconds, yes, 12 seconds, 3 meters, you think is, I know some of us can do it in 2 seconds, you know, but in elderly people, it's not that easy for people that are frail. And then these are one of the things we use to observe. Lower extremity weakness, even to get up from the chair, you know, becomes an issue. Or while standing, And some, when they walk, you can now see unsteady gaits. Gait is another thing that can lead into so many movement disorder diagnoses. All right. Then for us, the medical field, or even your family, taking a good history, ask for previous falls, medication. Now, when do you feel dizzy? Is it when you take your medication? What happens? This is that. And the nature of fall they have. I mean, this is for us, the medics. I don't want to bore you people with all this. Remember, people don't like reporting fall, so we should ask them. As when you come in and you see your elderly relatives, talk. Let me tell you, some people have been in their homes, falling down, and stayed there for the whole weekend. Nobody, till the neighbor realizes that, look, we've not seen her come out of the house. And they go and knock. That's why some people have pendants and all those things to alert when they're in trouble. So don't take it for granted. Elderly people need our help. So now we're not going into approaches to falls prevention. Attempt to modify the risk factors identified above. Remember what I said, intrinsic factors like sicknesses and all those things you can manage. Blood sugar, when your blood sugar is too low or too high, it causes a lot of things, your balance, your stability. Extrinsic factors, environmental factors like, why will I allow an elderly dad to have live in a cluttered place? Some like hoarding, but you try a way and find it safe for them. Take away things that they can bump into, make sure that the carpet is not loose, it's not slippery. If NHS hospital now, there's a general stockings everybody wears, non-slippery stockings. The underneath has got ridges on it, so when people stand, they don't slip easily. Because falls is a big issue. Falls is a very big issue, like I explained earlier. So you look at all those things and see how you can modify. Then you educate them. Look, you mustn't run to get this phone. You mustn't cook all the time. There are, HUK, there are so many people that can help you. So there are so many things you can do. You mustn't run at this time. So look at that. Patients require more complete assessment of risk factors of falls. And those who have difficulty getting up and go test, like I mentioned earlier, those who are giving you history of multiple falls, those who have been evaluated after a recent fall, after an acute injury identified and treated. Let me tell you, in this profession with elderly care, most of them don't want to tell you what is wrong. You have to probe like a policeman to get it out. And let's discuss the consequences of falls before we start rounding up. Falls reportedly contribute to 40% of people going into nursing homes. 40% of people going into nursing homes. And other statistics to know, over 50% of falls among elderly people result in an injury. That's quite high. Although most injuries are not serious, maybe contusions, abrasions, but fall-related injuries account to 5% of hospitalizations in people above 65, and 5% of fractures and all those things. Then 2% falls result in hip fracture. Why am I stressing on hip fracture? Most, if not all hospitals, functional hospitals in NHS have orthogeriatric center where they look after hip fractures, and look at why. Because about 5% of elderly people with hip fractures, or if I say frail people with hip fractures, die while they are still in hospital. So it's not only the hip, they've had a hip fracture, they can't move. When you can't move, complications of pneumonia sets in. Being in hospital alone is a risk factor of its own. A lot of things sets in, and then people end up dying. 5%. And now the day I saw this second statistics about overall mortality, we're talking about death in 12 months. So if you check those that have hip fractures, you see, this is the main reason why we should prevent these falls as much as possible. And I thank the team for organizing this. So if you check that in 12 months, in a year, go and check the statistics of those that had a hip fracture. 1/3 of them die. It's a big thing, and it's preventable. So these are the statistics I want to throw at us. And, my continuation of what could cause increase, falls, what falls will bring all about, increased risk of injuries, hospitalization, being admitted into hospital. What do I mean by institutionalization? This is when people now have to be sent into care home and nursing homes, warded accommodations. They now lose the ability to live in their own homes, which in some cases are preventable if they didn't have a fall. But now some people because it takes them so long to be in the bed, it takes them a long time to recover. Even when you send them for rehab, some of them don't have the rehabilitation potentials. Again, the physiotherapists can't do much with them. They end up, let's go and find. This one is not even a case of carers coming into the house. This one needs 24-hour care to be looked after, and they end up in institutionalization. And then with falls come injury and incontinence, and of course, the fear of falling is never a good thing. I've seen people that told me, oh, they fell. Asking how do you describe it? Say, I just saw the ground come into my face. You can imagine the scare, the fear of falling, and they wouldn't want to go out again because they don't want to go out and be embarrassed. They want to go out for a meal. They don't want to go out with family activities like weddings and all those stuff. They lack confidence in themselves. There's decreased mobility. The conditioning is when people come in the way they are, we see what is the pre-admission condition. Pre-admission, this lady was driving her car, going around, doing all sort of things. And then she was, I know, she just ignored and fell, twisted her ankle. Now she can't do much. She's now laid in bed. By the time she's been in bed for 1 month, walking becomes like a little child learning how to walk again. And you can imagine, it may not be wheelchair bound or hoist, So what are the other complications of fall? Death, like I said before, head injury. People on blood thinners like warfarin, apixaban, all those things. If they fall and bang their head, we see them a lot. Catastrophic bleed, death. So is that big? The neck of femur fracture, which is the hip fracture, ended up in surgery with all the complications. Even when you fall in, you're well, this thing, you now end up in hospital very unwell. End up in hospital very unwell with infection. And that doesn't help. Nosocomial is hospital-acquired infections. Now, little things, I don't know, time permits. Dr. Patrice, how much do I still have left?
Yes, you have. Yes, you have time. We just want to have time for questions, and yes, so you can finish off this presentation. That'll be great.
Okay, thank you. Yeah. So I've just described some investigations we do. Simple things you can help your relative do. Make sure their eyes, their glasses are okay. They can appreciate. Take them for regular referrals. If you notice there are balance problems, what's causing this balance? They're not normal. Your gait has changed. The way you're walking from side to side, vertigo, that's, always feeling dizzy, are they acute and chronic conditions? How are they managed? Don't overlook simple infections. Don't laugh at it. Don't say, oh, I'm having these palpitations or chest pain. No, and then you want to just go and ignore it. It doesn't matter. I've seen people that say, oh, chest pain comes with old age. No, it doesn't come with old age. It's abnormal. Have it checked out. Do you know that things like anemia can lead to falls? Why? Because anemia, when somebody has got anemia, blood count carrying component of the body is very reduced. They'll be feeling short of breath. They'll be feeling, dizzy, and all sorts of things, and they end up falling. Parkinson's disease, another movement disorder. People are, in Parkinson's, they get very stiff, and maybe they're not taking their medication. They run out or they ignored it. That's why we review them in clinic more often. So you help your people to look into what's causing this and see the chronic conditions, even the acute conditions, they can be sorted out. Syncope, just collapsed. Why? It needs to be looked into. Causes due to peripheral dilatation, there are some things that cause people to just collapse, hypotension due to orthostatic hypotension. And what do I mean by that? When your blood pressure drops, when there's difference in height, maybe you just stood up quickly. So I normally ask my patients, when you stand up, do you normally feel dizzy? You know, because there and then they might not be dizzy. There's something we call sitting or lying and then standing blood pressure. That would tell us the person is sat down here, he's normal. Immediately he stands up, he start feeling dizzy. You know, so many people have learned how to manage themselves when they stand up. They don't stand up too quickly, or when they stand up, they give themselves time to get their balance before they move. Because they stand up now and move, they are the risk of fall and causing harm. So, but if you can speak to your doctor, find out if you're feeling dizzy when you stand up, let him look at your medications, let him check your blood pressure. At times, some medications we give to help boost up. At times, it might be so drastic, you know, but these are things we need to look at. Simple things like dehydration, not drinking enough water. Is a big problem. I know many young people don't like drinking water. Talk less of old people, they don't even like drinking water. Keep a little jug of water beside them. You come back, it's still like that. Find out if you're gonna modify things, even pressing orange into their, give them tests, squash that are healthy, or anything to make them drink, because dehydration causes a lot of things, both constipation and UTIs and a lot of things. Now, other thing I want to say about, people can just collapse because of you giving them a news they weren't expecting. We all know this. Fear, anxiety, fright, and then carotid sinus stimulation here. That you have to be careful with that. And then one thing I want to mention anyway, if you're on the medical and acute side, you understand that if somebody collapses, you have to look at if the person has developed a clot, and you take it from there. Some people have very poor hearts, and then weakness going out, the blood flowing out when there's a tight heart valve. The blood cannot pass, and then it cuts off blood supply to the brain, and the organs on the floor. And of course, substance abuse, alcohol, and those are taking antihypertensive medication for blood to reduce their blood sugar. If you're doing so much, it can lead to problems. So I mentioned the investigations we do when somebody collapses, when somebody falls. We look at the bloods, we check the ECG in the hospital to make sure there's no heart attack. At times we don't get to see, if we're not convinced, we'll give you a tape to monitor your heart for 24 hours and 72 hours. And then we check the chambers of your heart, tilt test, CT head. So many people just fall down and they stand up and tell they're okay. No, they are not okay. You do a CT head, you find out that there's a massive bleed there, or even there's a brain tumor, or there's something that is, a secondary person in the skull causing the problems. I've talked about polypharmacy in the elderly, when somebody's more than 4 drugs. And I've not mentioned so much about dementia here. That's memory impairment, which is a whole topic on its own. Happy to deal with it. But memory impairment is a big causing factor for falls. Dementia, when people don't even know where they are, well, they've got to understand. So it impacts on other things, because they don't even appreciate that, maybe they have a sore leg, they have this, they're forgetful. And they jump up, they do things they're not supposed to do, and they end up falling. It becomes a big problem. Treatment and prevention, if you find out the causes of these, reversible causes, if you remember the intrinsic factors, environmental factors, and the things you can do for your people around you, if you remember the treatable, reversible causes, and how you can do situational, teach, like we're doing today. And then finally, I want to thank the organization and everyone here, because we have elderly people, and what we're doing is very scriptural according to the Bible. Honor your father and your mother, that your days may be long in the land the Lord has given you. And I know that I've tried to do this, and I'm happy to have more questions. Thank you very much.
Thank you very much.
Yeah.
Thanks a lot, Reverend, for that very informative presentation. And there's so much we can take away from it. And while you were speaking, we've got quite a few questions in our chat box.
Okay, I've not looked.
So I'll just start off with the first question. Someone asked about delirium and whether it's associated with aging, and can that happen at any age? And obviously, how does it affect you as you age?
Good question. Delirium, like, is an acute confusional stage, right? You rarely find it in younger people, right? It's mostly in the elderly people, frail people. Frail. Remember the definition of frailty. You get to see delirium in frail people, but it's mostly seen in people with memory impairment, to be honest. And we have people we admit under the elderly care team that are frail, not because of their age, but because they are like 65 and they're in a nursing home, they have a lot of challenges. So you tend to see a lot of delirium can happen mostly in the younger people, in the older people, sorry. For a younger person, depending on what you mean by young, 65 and above, if the person is frail, yeah, they can get delirium. Thanks.
Okay. So they can get it, you can see a lot of it if they're in hospital, they're elderly in hospital, they get confused. That is an acute presentation, and then once they get better and they leave hospital, they can get back to normal.
Start getting back. There are a long list of things that can cause delirium,
right.
Like things like constipation, dehydration, being in a new environment for, infections that we know, broken bones, and lots of things that can cause. I've got limited time to not able to explore more. Yeah.
Of course, that could be a risk factor for falls, as you mentioned. Yeah.
It is.
So what I did like about the presentation is that, you went into detail about, all the risk factors, age, over 65 and then over 85. But I did like the fact that you mentioned because you're 85 and over, it doesn't mean that you're frail. Okay.
No.
Only 25 to 50% of people are frail. That means 50% are not frail.
I'm not frail,
And we can do a lot before we reach that age to help us getting that very first risk factor, which is the fall. The first fall, it seems things can go downhill once you get that first fall. But there's a lot we can do even after the first fall.
Yeah, exactly.
Yeah.
I really struggle with time to fit in everything I need to say. I didn't talk about the exercises, role of exercises.
But we can talk about that. Yeah, we can talk about
you.
that as well, because that's so important, maintaining that body mass, and as you're getting older, that helps with your coordination as you get older. Someone asked, they mentioned, unfortunately, there are a lot of senior citizens on one or on two or more medications. You mentioned 4 or more gives you that increased risk factor of fall. But sometimes these medications can cause dizziness as a side effect and be a contributor to falls. What should senior citizens do if this is the case? That's the question from Montrose.
Good question as well. At times you ask yourself, are they not doctors that are giving these medications? Are they not doctors that give it to you before they know you've had a long list? There's some people that have 16 tablets every morning and all those stuff. And you see them, when they end up in hospital, start reviewing what is causing this. So, if you really need to be on this tablet, please, you need to be on them. Please don't take off your tablets if your GP or your doctor hasn't advised you otherwise. But just like increases your risk, that doesn't, going outside driving increases your risk of an accident, but that doesn't mean you're not going to go out to drive. You know what I mean? It's just something we have to be aware of.
Yeah, we have to mitigate these risks. I have a question, a statement that says, I have falls not dissimilar to a dimmer switch being turned down, then up again. What causes this and what is it called? She suffered for years with increase in weight as well. So falls not dissimilar to a dimmer switch. not quite 100% sure what's that similar to.
I didn't get what a demo switch is, to be honest.
Yeah.
But I think I'm happy to speak to this person one-on-one later. I
Sure.
don't mind. Don't mind.
Getting
Understand
some more
how
details about that.
and
Yeah.
process.
Yeah, exactly what's meant by dimmer switch. Someone commented that she's got osteoporosis and spondylitis of the spine, and I sometimes fall and have swelling and bruising, and I am aware that bones can break. As you mentioned, osteoporosis is one of those risk factors for fractures. And she wants to know what she can do, obviously, to help prevent that, even though she's got a diagnosis of osteoporosis. And I know you mentioned being aware of your condition, of liaising a lot with your doctors, your GP about the medication you're taking. But osteoporosis, do you find that is a big risk factor in a lot of your patients?
Oh yeah, most patients that have fallen and broken their bones are osteoporotic. Like she mentioned, number one is knowing that you have osteoporosis. Number two is whether she is on the treatment for bone prevention, bone protection, bone protection. So there are so many things. Over the counter vitamin D's and all those things, calcium, these are the first steps. But be guided by your GP. When it comes to osteoporosis and the kind of treatment needed, there are so many tests to check before they issue the treatment required. So that treatment, because osteoporosis means the bones are losing, the normal bones are losing calcium, losing the things that make it very strong. So do you have to, what do we do to prevent it from oozing off the calcium deficits and all those stuff? So there's some medications that stop it, different types. There's some you don't give, there's some you give depending on age and conditions you have. So it's not something I can say here. It should be a one-on-one, but yes, please be aware there's treatment for that and to help the bones become less brittle.
Okay. So they should be guided by their doctor, their GP.
Yes, please. Yeah.
On what medications to take. You mentioned sometimes that it's sometimes difficult to get a history out of the elderly about their falls, and someone did mention that the senior citizens don't always want to admit that there's something wrong, and that's where an experienced well-being coach can help. But I do know that once you have an attentive family members, that accompanies your parent or your elderly relative to the appointments, they too can be a great aid in helping the elderly patients.
Just like,
so what? Sorry.
Go on.
No, I'm just wondering what.
How do we get around it? You're very correct.
How do we get around that? Yeah,
because just like children, I'm not like belittling in an elderly, but we have this mindset. So if I have an elderly person completely confused, doesn't know what, I'll find out where does he or she live, and I'll ring up. If it's care home, I'll ring up and get the habit, get the mechanism of fall if it was witnessed or an unwitnessed fall, or if the person is at home, does she live with anyone, or if he lives with a wife or a partner, it makes it easier, or a husband. Then we ring the person to get the full picture. If not, do they have carers or do they have relatives that are? So we rely on other pointers and then see what we have in front of us. We'll check the ECGs, check all those things we can do, and then we'll get collateral history, we'll call it, from people, caregivers, and family.
Okay. What about obesity? Someone wants to know, can obesity predispose one to fall?
I think that's a straight, it will predispose one to fall because, don't get me wrong, many people are obese because they cannot help themselves. So not judgmental for people being obese. So it does prevent the person from falls, it does predisposes the person to a lot of problems with intrinsic factors that we mentioned, long-term morbidities out there eventually. So there's some obese people that are very athletic, they can, very swift on their feet and everything. Then some that are not opportune because there's some people that take tablets that make them obese in the first place. And it becomes a challenge. So yes, it can.
Okay. And you were speaking about the diagnosis of frailty. And someone wants to know what the differences between frailty and comorbidities are, and how these two can predispose one to falls.
All right, good question. Comorbidities are long-term conditions, like I specify, like diabetes, like hypertension, like atrial fibrillations, kidney problems, like things that are long-term conditions. Now, frailty is when the internal reserve of someone is so much affected that they are not performing their optimum, right? So you can see that when somebody has got diabetes, somebody has got hypertension, has got heart failure, invariably these are limiting the person and pushing the person towards becoming frail. And if you remember the 7 Prisma questions I used to help us to find out about frailty, say at some point you said, does your health limit you from getting out? Or do you depend on people for help? Somebody that's got heart failure, a comorbidity, a morbid situation, cannot run up the stairs. Depending on the stage of heart. I mean, if sorry, New York classification 3 or 4 or higher, cannot. So you can see that the person invariably ticks the boxes for frailty. So that's the link, if I may say, of having comorbidities and then being frail.
Okay.
Dementia is a comorbidity. Dementia is a diagnosis because the brain has got a problem and is not directing the body very well, and then it becomes an issue.
Yeah, I know we didn't go into detail about dementia because, as you said, that's a separate topic in itself.
Yes, so many types, yeah.
Yeah, but I could just imagine the difficulty with managing dementia, someone with dementia, and trying to prevent that person from falling. It is probably a minefield.
Yeah, it is.
And that's where the family support of the family comes into
very handy.
Very, very, very big role of support of the family. But as you mentioned, there are other organizations within this country that can help the elderly. Age UK, you mentioned. And are there any other support groups out there that you know of that are quite useful in your practice that people can refer themselves to, or maybe relatives can refer their elderly patients to?
I think Age UK does a lot in most localities. Meals on Wheels, people that come to help people, they're feeding. And I know when I was working at Scarborough Hospital, there's a community therapy team, they call different names. So therapy team with occupational health and physiotherapy, and they work at charities. So each locality has got people actively. And then some faith-based organizations like churches and come up themselves up to help. I think people are writing things on the shelf. So each locality has got people set up. Marie Curie, I think they do something about people that are very ill and terminal. And so there are very many organizations that really look into elderly people. So over here in my Mid Yorkshire, which is where I work, there are different signposts. So we have Age UK coming into our wards when we want to discharge people that live alone, to take their details and see what specifically they want. Do they want people company? Do they want assistance with food, assistance with shopping, finances, and all those stuff? So yeah, I think they're the first to signpost, and then we'll look at other things. So ask individual locations where we are.
Great. I'm glad there's so much support out there. And just one final question. someone wants to know if you're young and you have arthritis, obviously you're not very mobile. You're not able to run up the stairs. Are you then classified as frail? Does that come under your classification of frail? Because you mentioned 3, is it 3 out of 7 attributes?
I don't think a very young person that just got only arthritis, that, pain here and there, limiting their mobility will be frail, I would tell, in short, younger people that will take into our elderly care as frail, in most cases, they are institutionalized. They live in a care home. They need a lot of support. So if the arthritis have made it that you now need carers coming in to help you with day-to-day activity, but that's frailty. But if it doesn't, it's not just running. I know I've used running up a lot. People live in bungalows. They don't need to always live in upstairs. So if your condition is not limiting you from doing your day-to-day activities, by all means, you're nowhere close to being frail.
Yes, I think that more pertains to a certain age group, isn't it? If you're 65 over, 85 and over, and you've got comorbidities. Great. There are lots of community groups out there mentioned in our chat group aimed at the Black community, in particular, the African Caribbean Care Group. So that's one organization aimed at the Black community to help with frailty and the elderly, and also they would know a lot about fall prevention. So I just want to wrap up this health hour. Dr. Anochie, it has been quite informative and a reminder that we need to help our elderly parents, our elderly relatives. We need to be there for them. We are all a community, and the entire community, including the church, the doctors, the hospital, the care homes, they're all there to help our elderly people, our elderly relatives as they age. And, one day we know we'll be there as well. So it's got to take all those preventative measures, exercising, weight-bearing exercising. I know it's one of those things we can do when we are younger to help strengthen our muscles and help our coordination. So that is kind of maintained in our elder years. And I just want to remind our viewers that this presentation is available on YouTube. There is a link in the chat group. And also that we'll also be covering dementia in our health hour on the 30th of September. So that is a great presentation to join. And so I will hand this forum back over to Natasha. I believe she wants to just mention about the gala coming up, exciting for Khan. And I just want to thank you so much, Dr. Anochie, taking your time out to come and talk to us. Busy schedule, pastoring and doing
enjoy both.
The elderly, that's right. And thank you so much for taking your time.
You're welcome. You're welcome, Patrice.
Talk to us.
Thank you very much. My pleasure.
You're welcome. I'll hand over to Natasha.
Hello, thank you all for this great session. Both doctors really interacting and generating thought-provoking conversations that really helps the health literacy of our community. So thank you so much for your participation and contribution and time on a Saturday morning. Much appreciated. I'm just going to quickly share my screen. Perfect. So I just wanted to catch you up on what Canon is doing at the moment. As you know, every Saturday we have Health Hour, CATIP Health Hour, and next Saturday won't be an exception. On the 16th of September at 11 a.m., we'll have our medical professionals speaking to us on various health topics and conditions. And this Tuesday, we have Healthy Hearts. This week, the subject will be on sustaining healthy habits. This is hosted by Dr. Hiba. We have our guest speaker, Dr. Robert, and always our physical instructor, Orlando Grant, will be at the end, making us move. But really join us on Tuesday. It's in the evening to be able to accommodate everyone. So yeah, join us at 6 o'clock. 6:30 this week, actually, it changes too. So 6:30, this is a very important announcement. We have tried to move it to later so we can accommodate more people from our community after they have left work. So we have a family and advocacy session on the 13th of September. So it's upcoming next week on Wednesday. So it's from our advocacy team, and they can help you with a series of complex issues regarding a family or challenges that you might be facing, children and adults as well. And on the 15th, our advocacy session team has been very, very busy. So they have a modern slavery and human trafficking event. The subject is Leave No One Behind. And it will happen on the 15th of September in person at 4 p.m. This is a free event, and will be very interesting to hear from our guest speakers. So yeah, do join us on St. Thomas Center in Hardwick. We have our Green and Arts Wellbeing Services. So Can really takes a holistic approach to health. As you can see, we try to approach health from various fronts, and one of them being Green and Art. So we have a service where you do creative activities. I know at the moment they are building teddy bears, but in a very, conceptual approach to it. You really learn the steps of creating art and expressing yourself through art. You also get to socialize, so you can join them in the Stockport Hub or our Bolton Hub. It happens weekly. There is the contacts on the screen, as you can see. And it's that time of the year. Black History Month is approaching, and it is very important for us to celebrate Black History Month and the achievements of our community. So we do have our gala in October, the 28th. Tickets are available. Unfortunately, the early bird has ended, but you're still on time to purchase your tickets or tables for you and your organization. So join us on the 28th in the Lancashire Cricket Club. There will be plenty of entertainment. We'll have an award ceremony. There will be obviously performers. Our presenters, Mike Schaff and Sonia Joy, will be entertaining us and hosting us throughout the evening, and obviously 3-course meal. As I said, is in the Lancashire Cricket Club, so it's a very, very is a glamorous venue. And just before that, we have the Black History Month civic opening. So basically, it's a Greater Manchester Black History Month launch event. So we launched the Black History Month for Greater Manchester. Do join us. This is a free event on the Manchester Cathedral. We are honored to be able to host in this venue. As you can see, keynote speaker, Dame Elizabeth Neku. Apologies for not being able to spell the name properly, but you can see our guest speakers. We also have Charlotte Norman, Andy Berman, and Christian Weaver. So do join us. I think this is an unmissable opportunity. And last but not least, this week as well on Wednesday, this is an invite specifically to people that work in media, comms, social media as well around the country, if you are happy to join us. So it's on this upcoming Wednesday. The link to register is here, but I'll put it on the chat as well. Come and join us to network and know how to get involved in Greater Manchester's Black History Month. Thank you. that's it from my side. Thank you all for joining us today. Rest of a great week.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.